Welcome. My name is Paul Naji. I'm a faculty member at Johns Hopkins University, and I'm really privileged here to talk to you today about the work we're doing on the virus registry and how we can lower the cost of data collection, which is always a barrier for clinical registries, and how we can automate the extraction, transformation, and loading of this data into a common data model, all while working off of EMR data. So this is an exciting project. We all support a lot of different clinical registries, and it can be very time consuming to do chart reviews to pull out the data necessary for each registry and be able to submit it in a timely fashion. And so this project involved the use of the development of an edge node tool. And so our goal is, as part of the virus registry, to be able to collect lab data, procedure data, diagnosis data, and medications from patients seen at a health system with a diagnosis of COVID with symptoms, and be able to do so and collect the data necessary for the virus registry without requiring chart abstraction from any clinical professionals. So this should be, we're hoping this is a major improvement in efficiency and time. We're making this tool an open source package, and our goal is to help 60 health systems to help them in the use of this tool and the evaluation of this tool to help them lower their cost of mapping their data from their EMR vendor into an OHDSI OMOP common data model. Now, most EMR vendors have a proprietary data model, and so so we are building a bank of all the common data model, all the common EMR vendors, and the mappings from them as a starting point. So the components of the Edge Node tool has 7 different components to this tool. The first is that it's going to be a web-based tool with a user interface to help an individual to map custom concepts. And so you can look within your EMR's database and be able to map fields to a common standard terminology and their values. And so this is all done through a graphical user interface and to help them with the mapping of their data. And this is often needs to be done for vitals, for things that are done within custom forms that are generated within an EMR. So the second is we're building a base configuration setting for major EMR vendors like Epic and Cerner and others, and so that we're hoping that this will significantly reduce the time for a data analyst to have to map data from an EMR vendor into the common OMOP data model. The third goal is the configuration management tool. Is as they're doing this ETL, as they make changes to it, this will help them manage those changes as they move forward, and provide them with an ETL process inspection report that will study their infrastructure, the performance, and their data mapping to make sure everything's done in a successful and timely way to be of sufficient quality for submission to the virus registry. And with that includes the data quality dashboard, which is a framework that is used that runs over 3,000 different data quality tests, looking at the completeness of concepts, the plausibility of the timeliness in the concepts, as well as the conformance of that data. And so, completeness, conformance, and plausibility tests are done on our data set. And then we'll be subsetting that data set for patients with a confirmed diagnosis of COVID and with exhibiting symptoms and potentially being hospitalized into a cohort, and then de-identifying that data, only taking the categorical fields and submitting that to the virus registry. And so this is the 7 components of the Edge Node tool, and our goal is to really significantly reduce the time it takes for a EMR, for a health system to convert their EMR data over to a registry's format. And I want to back up a little bit and talk about some of the major advantages for doing this. While they're doing this for the virus registry, what's nice now is many registries are converting their data into the OMOP data format. It is a flexible data format that can support a lot of EMR clinical data observations. And so we've now seen the NIH, all of us, uses OMOP as its data model. The National COVID Consortium last year uses OMOP as its data model. And in fact, it's become a de facto common data model throughout not just observational research networks, but through clinical registries as well. We're seeing many more clinical registries move into the OMOP model. And this significantly reduces the cost for a health system. So instead of supporting different data models for every registry, now they can convert their data to OMOP and computationally subset that data for that cohort and then submit it off to that registry in an automated fashion. So this, we're hoping, is major labor savings for EMR for health systems, not only for this registry, but for every other registry that they also support. So the three main innovations in the OHDSI open science community are the fact that they have built out a common data model from claims and EMR data tied to standard terminology. So the concepts are now tied to concepts in standard terminologies, and this acts as a Rosetta Stone from all the different fields and databases within an EMR vendor into a common one that can then be tied to a common meaning, tied to a standard terminology. The second major innovation is that it also is an ecosystem of informatics tools and provides validated statistical methods on this observational health data to do survival analysis, to study at the data quality, and to be able to then perform study protocols on that data in a common expression language. And lastly, it has also created an open source community and a research network where we've now mapped over hundreds of millions of health records from around the world. There's over 350 databases around the world using OHDSI with over 850 million unique patients in that data. So the odds are good that now, as registries move over to the OMOP standard, that health system has already converted some of their data to OMOP for other purposes, whether it's research or clinical registries. So the data model collects all the major symptoms and conditions a patient might have at the time they're being treated. It captures their interventions, from medications to procedures performed on them, as well as any measurements, any laboratory tests, any vitals that can be mapped into the standard terminology. And one of the powerful things of OHDSI is it's not just one terminology. It actually maps all of the major clinical terminologies that are used throughout the world. So it's actually over 153 controlled vocabularies mapped to 9 million different concepts used for coding of data in healthcare, from the NIH, the ICD-10, to SNOMED, to LOINC, and more. And so so defining this data to these standards is a great way of generalizing its meaning so that then you can express it in a very common way. That means that when you've converted your data to OMOP and you run an analysis on that data, you can share that analysis with another site, or you can combine the data from those two sites with a much better probability of having harmonized data that means the same thing across those two sites. This data model is fairly straightforward. It involves, similar to an EMR, it has a patient index. Below that is a encounter index. And below the encounter index, which is the visit, we have all the major data fields for procedures, medication exposures, diagnosis and conditions, measurements, observations, and it allows you to have ability to do calculations on that data as well, like looking at the era that a patient was prescribed a medication, how the duration of a hospital visit, and it also supports cost data for doing health economic analysis. And so this, it's all tied to these standardized vocabularies. The vocabularies have their own hierarchy, and so you can actually do a lot of descendancy mapping on concepts. As we know, there's a lot of groupers in our International Classification of Disease. Most of them are hierarchical vocabularies where we can then translate them and traverse them to be able to look for groups and subgroups. So George Ripsack's one of the founders of the OHDSI community, and this is really their goal has been to create an accessible, reliable clinical evidence by accessing the clinical experience of hundreds of millions of patients across the globe. And this is something that has become really the de facto standard for sharing clinical data for research purposes throughout the world. And this is just showing the recent growth in the number of sites that are using OHDSI and OMOP as a common data model, as well as a number of patients that have been mapped in the research network. So it really has grown significantly. The other registries have been looking at mapping into the OMOP common data model. Here's a very recent paper on pulmonary hypertension mapping, and they were able to successfully map facilitates a more efficient collaboration between researchers and the ability to establish these federated data networks. And so most work's shown that OMOP is able to support a lot of the registry's data models in being able to do this conversion. So here's an example of what the web-based mapping tool would look like, where on the left-hand side, you have a custom database around your patients that's coming from your EMR vendor. All the variables have relatively have names to them that you have to interpret and understand what the data is. And on the right-hand side is the standardized OMOP data model. And so you'll have to map the different fields into their values as part of the user interface and identify what standard terminology you want to map it to, what concept we're looking for. So in this case, we're looking for a gender concept, and we're looking for a standard concept used within OHDSI. So it'd be mapping the values of male from the source EMR vendor concept field into a gender concept ID that would be associated with being male. And so this is basically every value in the OMOP model is a concept. Every condition, every measurement, every lab is tied to a concept, and so it is able to be flexible and extensible. The second part is a documentation tool where we have all of the extraction, transformation, and loading scripts that are used to convert all the proprietary EMR data into your OMOP data model, built out into a documentation guide where your researchers, where your administrators can then evaluate it and use it for change management purposes, and to make sure that the provenance of the data is what you assume it to be, that where the data sources are being mapped from, what fields are going into, can be then used and indexed and searched easily through the documentation guide. And also as part of the guide, we've provided best practices for DevOps, for how to maintain a production level on the database, how to manage your runtime extraction process to look for any faults in the ETL process. And then with the Edge node comes the data quality dashboard, which is actually will be a website where you can go and navigate all the different tests that are run on your data to see the reasons for the failures and investigate if there's things in there that need to be fixed. Just to see if you're missing certain cost data, which might not be necessary for the virus registry, you can ignore certain failures. But it's very useful to be transparent about what tests your data passes and what tests it doesn't. The types of tests range from relative conformance, matching to a range, to completeness for how complete the field is, to atemporal and temporal plausibility, making sure that things from month to month change, don't have an unexpected number of changes, and that you're not seeing a large number of values outside of the expected range. And inside there, you actually can get detailed reporting of exactly which tests failed, and you can even actually see the commands that caused the fail, so you can find those patients, be able to look for what might be going on in data quality. So this Edge node tool is going to really help us and help a health system manage their clinical data from their EMR data source to bring it into a curated common data model that they can then use as a base for submitting into a registry. And so this is an exciting project. We've made a lot of progress in the pilot, and we are looking forward to taking it forward. Thank you.